Okay, pain management, pain review of medication and interactions. Objectives, define pain, commonly used terms, describe nociception, basic process, and normal pain transmission, related harmful effects of unrelieved pain, identify pain and comfort management in any setting, including special conditions and key concepts of analgesic therapy. You can see the others part of it here. So, what is pain? Pain is a universal human experience that is necessary for its for it serves to protect one from injury. Pain is one of the most common forms of acute pain. Among surgical patients, acute pain is experienced by 82% from the period after surgery until 2 weeks after discharge, as revealed in a national survey. 86% of those patients said that they had a moderate, severe, or extreme pain. Pain is whatever the person experiencing the pain says it is, existing when it says it does. Nociception pain usually responds to non-opioid and opioid therapy. Nociception pain is usually 0 to 7 days in duration, but lasts less than 6 months. Pain starts with the injury of the body, either a mechanical, thermal, or pressure. It all starts at the tissue level when it is damaged and releases sensitizing substances such as prostaglandins, bradykines, serotonin, substance P, and histamines. This creates an action potential of the sodium and potassium pump called transducence. This is followed by transmission, which occurs in the dorsal horn of the spinal cord, and then it goes to the brain stem and the thalamus. The release of substance P and other neurotransmitters continues across the synaptic cleft between nociceptors and the dorsal horn neurons. From the dorsal horn of the spinal cord, neurons such as the spinal thalamic tract ascend to the thalamus. Other tracts carry the impulses to other areas of the brain. The thalamus acts as the relay station, sensing the impulses and to the central structures for processing. At this point, you have the perception of pain. The final step in the modulation of the pain neurons originated in the brainstem descend to the spinal cord and release substances such as endogenous opioids, serotonin 5-HT, and norepinephrine that inhibits the transmission of nociception impulses. Types of pain. There is somatic pain, arises from bone, joint, muscle, skin, and connective tissue. Visceral pain is poorly localized, often referred to as distant pain, arises from the visceral tissue. This is known as nociception pain. The Joint Commission of Accreditation of Healthcare Organizations, JCAHO, now encourages hospitals to develop comprehensive programs for the assessment, treatment, and documentation of an institution of quality improvement efforts related to pain management. Despite the guidelines of the requirements imposed on hospitals, pain continues to be undertreated. Good examples of visceral pain is the shoulder and upper right quadrant pain from gallbladder surgery. Types of pain continued. You have neuropathic pain. Neuropathic pain is distinctly different from nociception pain. It is pain sustained by abnormal processing of sensory input by the peripheral and central nervous systems. A vast number of syndromes exist that are considered neuropathic in nature. The pain reporting by the patient may be disproportionate to the physical findings. Centrally generated pain, deafferentation pain, injury to either the peripheral or central nervous system, sympathetically maintained pain is associated with dysregulation of the autonomic nervous system. Then there is peripherally generated pain. The first stage of pain is the transducence of the pain. This happens when the cells are injured and release a sensitizing substance that generates and creates an action potential. Stage 2 is the transmission of the impulse and the action potential, and this occurs in the dorsal horn of the spinal cord. And this is why a patient with a spinal cord injury may not feel pain. Then there's stage 3, which is the perception of the pain that leads to the stage 4. The modulation of pain comes down from the brain and tells you that you have pain. The harmful effects of pain, this is like untreated pain. Endocrine system, you have an increase in ACTH, cortisol, antidiuretic hormone, epinephrine, norepinephrine, growth hormone, catecholamines, which are horrible things to have released in your body, renin, angiotensin, aldosterone, glucagons, interleukins, decrease in insulin and testosterone. Think about all the parts of your body that pain affects and what it could do to the patient that is on the edge of a multi-system failure or just has a bad heart. Okay, cardiovascularly, you have an increase in heart rate, cardiac output, peripheral vascular resistance, systemic vascular resistance, hypertension, so on and so forth. Respiratory, you have a decrease in flow volume, atelectasis, shunting, hypoxia, decreased cough, sputum retention, and infection. So there's all kinds of things that are going on at multiple times in multiple places. Cognitively, you can have a reducing cognitive function, mental confusion, with increase in muscle spasms, increase in pain, decreases the bowel motility, increases in nausea and vomiting, depression and of immune response, and increase in infection. Decrease in sleep, increased in irritability, and less healing. Your body heals best when it gets sleep. All this happens when nurses and doctors under-medicate. The WHO stepladder, mild pain, 1 to 3 on the pain scale, would be aspirin, acetaminophen, NSAIDs, and plus or minus adjuncts. Moderate pain, which is 4 to 6, a codeine, hydrocodone, oxycodone, dihydrocodone, tramadol. Stage 3 or 7 to 10 pain is morphine, hydromorphone, methadone, and so on, fentanyl, oxycodone, and other things. This has been around since 1996, and it continues to be listened to and guiding the principles of pain control. Pain assessment, components of pain assessment. You want to have location, description, intensity, duration, alleviating, aggravating factors, associated factors, impact of pain on patient's life. Pain assessment starts with the admission of the patient to the hospital for pain assessment and goes on from there. Pain assessment continued, peripheral pertinent medical history. What medications are they taking? Which one? How long have they had this before? used them before surgery. Language barriers, understanding the scale, culture, physical condition, all these things are pertinent to assessing a person's pain. So then you go into location. You want to make sure that you have a location, quality, measuring, timing, setting, associated manifestation, and aggravating and relieving factors. Location, use anatomical terminology and landmarks to describe location, i.e., where is the pain? Does it radiate? Ask them to point to the location. Quality refers to how the pain feels. Is it sharp, dull, burning, stabbing, pounding, throbbing, shooting, gnawing, tender, heavy, tight? Ask them, what does the pain feel like? Measures. Intensity, strength, and severity are measures of pain. Ask them how much pain are you having now? What is the worst, best the pain has been? Rate your pain scale on a 0 to 10, and you have to explain that to some people. Timing, onset, duration, frequency. Ask them when it started, how long does it last, and how often does it occur? Is it constant or intermittent? Settings is how the pain affects daily life and how activities of daily living, ADLs, affect the pain. Ask where are you when the symptoms occur? What are you doing when the symptoms occur? How does the pain affect your sleep? How does the pain affect your home life, work, or social interactions? Associated manifestations, document associated manifestations such as fatigue, depression, nausea, anxiety, anorexia, insomnia. Ask what other symptoms do you have when you are feeling pain. Aggravating or relieving factors. Ask what makes the pain better, what makes the pain worse, what seems to trigger the pain. Are you currently taking any prescriptions, herbals, or over-the-counter medications? You want to ask them that. You have the pain scales. Now, the one on the left is what they call the FLAC Behavioral Pain Assessment. These are tools, and then you have the faces on the right. The faces used to be a round circle, but they found that having this oblong form better coordinates with people of color, and other people just seem to understand it better that way. These are tools that are used to assess a patient's pain level and are quick and easy to use. We have them in multiple languages and can be received by letting them know that languages you need, and we can get those to you. They are located in the Pain Clinical Manual. Allows for easy documentation and use. Okay. Assessment continued. Physical appearance. You want to look at what you're seeing and versus what they're telling you. Pain and discomfort behaviors. Pain behaviors are highly individualized in absence of any specific behavior. Facial expression, body movement does not mean that they are not having pain. For the shivering, administer the meperidine, Demerol as ordered, and that will help. Shivering increases the oxygen consumption of the body by 700%, especially right after surgery. Environment such as noise, noxious smells, or anxiety also help. So, assessment continued. Status of vital signs, airway patency, respiratory status, breath sounds, level of consciousness, pupil size. You have to look at all of this type of stuff to be able to assess your patient. Okay. Interventions, non-pharmacological, you want to try those first. Positioning, repositioning, elevated affected limb, applying ice as ordered, covering incision with a pillow and hold during coughing, provide music therapy or imaging. Some of these are for children and infants, and of course would not be done with adults. Non-pharmacological interventions are not to replace drugs. It is to help the patient and nurse to deal with the pain until such time as the pain medication is effective. Okay. Providing distraction techniques. Provide a non-stimulating environment. Encourage deep breathing, coughing. Use a pacifier for babies or a bottle containing glucose water. Being held in a rocker for them. Again, not for the adults, but for the younger children or babies. Apply warm blankets, burping of infants. Those are all things that you can do. Pharmacological interventions, non-opioid therapy is where you would start off with. For mild to moderate pain, acetaminophen, non-steroidal anti-inflammatory drugs, ketorolac, ibuprofen, COX-2 inhibitors, aspirin. We will discuss each of these and their interactions and counterindications. These are used in conjunction with opioid therapy to help the patient to deal with the pain of surgery or other pain that they may have. The adjuncts are other things that can be used to help with pain control and other than opioids. We have all seen Vistaril, hydroxyzine, can help with patients that have orthopedic surgeries, helping them control their pain. Some of these adjuncts are used in the same ways. NSAIDs are believed to act primarily on peripheral nociception through the inhibition of the COX-2 enzyme, or the COX enzyme, that synthesizes prostaglandins. A higher dose of chronic use of NSAIDs can cause gastropathic consequences, ranging from localized irritation to gastric mucosa or erosion, gastritis, or gastric hemorrhage. NSAIDs can carry a risk of other adverse effects. COX-2 inhibitors, selective NSAIDs preferentially inhibit the COX-2 enzyme and have a similar effect of other NSAIDs. Adjuncts, multi-purpose for chronic pain, anticonvulsants, tricyclic antidepressants, corticosteroids, anti-anxiety medications, local anesthesia, and ketamine. Continuous neuropathic pain, it sometimes helps with the antidepressants, tricyclic antidepressants, and oral and local anesthesia, anticonvulsants, and baclofen. We will discuss each one of these classes of medications. Malignant bone pain, corticosteroids and calcitonin help a lot. Postoperative orthopedic pain, consider muscle relaxants if patient experiences muscle spasms. All right, into the non-opioid therapy. Acetaminophen, the oral route is oral or per rectum. Dosage range is 325 milligrams to 650 milligrams. Dose interval is every 4 to 6 hours. Maximum daily dose is 4,000 milligrams. Half-life is 1 to 3 hours. Okay. Ketorolac is otherwise known as Toradol. It has a PO, an IV, and an IM dosage route. Dosage PO is about 10 milligrams. IM is anywhere from 30 to 60 milligrams, followed by 15 to 30 milligrams scheduled IV is 15 to 30 milligrams, followed by 15 to 30 milligrams scheduled dose interval every 6 hours, 4 to 6 hours for PO. Maximum dose is 40 milligrams uh, for PO and 120 milligrams for IV, and 150 milligrams first day IM, then 120 milligrams daily after that. Half-life is 4 to 8 hours, so you'd have to monitor that patient closely. COX-2 inhibitors, Celebrex is one of the common ones that we use. PO is 100 to 200 milligrams, 12 to 24 hour dose intervals. Maximum dose is 400 milligrams a day. Half-life is 11 hours. COX-2 inhibitors have some of the same major side effects as those of the COX-1, but have a lower incidence of gastrointestinal upset of the COX-1 and other NSAIDs. Aspirin, PO 325 milligrams, interval is 4 to 6 hours. Maximum dose is 4,000 milligrams a day. Half-life is a quarter of an hour to about a half hour, so they don't last very long. Okay. The aspirin also takes and can cause stomach upset. Anticonvulsants like gabapentin, Neurontin, route PO anywhere from 9 to 1,200 milligrams a day. Dose interval is TID. Maximum dose is 4,800 milligrams. Half-life is 6.5 plus or minus an hour. Tricyclic antidepressants, Elavil, amitriptyline. It's PO 50 to 150 milligrams. Interval is Q-day or 3 times a day. 300 milligrams is the max dose. Half-life is 21 hours plus or minus 5 hours. So that's one of the things that you're going to have to pay attention to. Gabapentin is believed to relieve neuropathic pain because as a 3-alkali analog and of Y-aminobutyric acid. Say that fast 3 times. So you have to work with that. Other adjuncts is anti-inflammatory medications, anti-anxiety medications, midazolam Versed, 0.5 milligram to 2 milligrams. It's IV. Dose interval is 2 to 3 minutes. IV maximum dose is 5 milligrams. Half-life is 19 plus or minus 0.6 of an hour. Corticosteroids, dexamethasone, Decadron, PO, IV, dose 2 to 6 milligrams every 4 to 12 for children, or for adults, excuse me. Dose interval is every 6 to 12 hours. Half-life is 1.8 to 3.5 hours in plasma and 36 to 54 hours biologically. Anti-inflammatory potency 25, which is stronger. Major side effects are related to individual drug. Can range from gastric upset and that, so it helps with anxiety and things like that. Flexeril oral, 10 milligrams 3 times a day. Maximum dose is 60 milligrams. Half-life is 1 to 3 days. So, I mean, this one lasts a long time. Robaxin, have taken that, IM or IV or oral. 750 milligrams, 500 to 1,000 milligrams IV or IM. Frequency every 4 hours PO or every 8 hours IV and IM. Maximum dose is 1.4 grams TID. No greater than 3-day therapy. Half-life is 1 to 2 hours. Major side effects related to individual dose range from GI upset. Flexeril really causes that. To seizures and anaphylaxis. Both can have muscle stiffness and pain related to the drug itself. For patients over 65, reduce the dose by half. Opioid therapy, narcotics. Morphine is the gold standard for pain control that all others are measured against. MS Contin, Oromorph, and various other names are for morphine. Route is always oral, rectal, IV, IM, sub-Q. Dose range is as follows. Oral is 10 to 20 milligrams. Long-acting is not similar in that the dosing is a little higher, 15 to 30 milligrams. IV, sub-Q, and IM range is 2 to 4 milligrams. IV onset is 5 to 10 minutes. Duration is 3 to 4 hours. Max dose is usually around 15 milligrams. Meperidine, Demerol, IM or IV, 25 to 50 milligrams. Oral route is about 50 milligrams. Onset's 5 to 10 minutes. Peak in 15 to 20 minutes, and duration is 2 to 4 hours. Meperidine has been removed from most order sets except for shakes due to the high incidence of seizure activity due to the accumulation of the byproduct of metabolism called normeperidine that decreases the seizure threshold. All the other side effects are the same as any opioid. Hydromorphone dilaudid, IM, IV, or PO. You can have half a milligram to 1 milligram IV or IM, and 2 to 4 milligrams PO. Same as any other opioid. Since dilaudid is more refined than others, it works a little faster. The information on the onset is variable and depends on each patient. Should wait 10 minutes before additional doses are given, IV or IM. And you use similar dose due to the fact that dilaudid is 6 times stronger than morphine, usually starting out at half a milligram and then move up to a total of 2 to 4 milligrams as needed. Fentanyl has been in the news a lot because people are mixing it with other medications, over-the-counter medications or illicit drugs. Fentanyl is a synthetic medication, works faster and peaks faster, but does not hang around as long. Does have a cumulative effect if given in large doses. Onset is 1 to 5 minutes IV, 7 to 15 minutes IM, peak in 3 to 5 minutes, duration is half to 4 hours, and half-life is 3 to 4 hours. Methadone or Adolphin, IV or PO. IV is 2 to 5 milligrams, PO is 5 to 10 milligrams. Onset IV is 10 minutes, PO is 30 to 60 minutes. Duration is 4.8 hours for both PO and IV. Half-life is 24 to 36 hours. So you have to be really careful with this. Now, you might get some pushback from patients because they think that methadone is for drug addicts. It is also a very good long-acting pain medication. Okay, opioid therapy, codeine, not used a whole lot anymore. It used to be used quite a bit due to the increased use of other drugs that are more effective in pain control, used more historically, not available in IM or IV any longer, only in PO form, and then only, sorry about that, moved it on accident, PO form, and then only mixed with another non-opioid drug, so like Tylenol 3s or Tylenol 4. Reversal agents. There are two. Narcan is the big one that's out there right now. It's an opioid antagonist. It knocks the opioid off of the cells that it binds to and therefore reduces the effectiveness of the opioid. The only problem is interval is every 2 to 3 minutes, okay? A titration. Duration is up to an hour. What's the duration of most of your opioids that you would use Narcan to reverse? Heroin and all those type of things. You're looking at 4 hours for them. So you got a half-life of 1 to 1.5 hours, and you have a duration of a third of an hour to an hour. So you have to watch these people very carefully. Flumazenil or Mazicon, that is your benzodiazepine antagonist. Those reverse Valium, Versed, things like that. Route is IV, 0.2 milligrams for an adult, 0.1 milligram per kilogram for peds, or 0.01, excuse me. Onset is 1 to 3 minutes, duration is 30 to 60 minutes, and half-life is 1 hour, plus or minus a half hour. So again, you have to watch these people. They do have side effects, symptoms of acute withdrawal, i.e. nausea, vomiting, agitation, tachycardia, hypertension, dizziness, and acute pain, increased risk of seizure with administration of flumazenil. Okay? So moving on, after intervention reevaluation, ask the patient if the pain medication or other interventions have helped. Make sure that what makes their pain better, what makes it worse. Just the same things that we asked before. What pain behaviors are you showing? Crying, moaning, screaming, facial expression, reduction of moving. Those are all things that you're going to see. Okay? So then you have, does the patient have multiple causes of pain? Do they have chronic back and neck pain? Is their bladder full? Nausea and vomiting, post-op complications, myocardial infarction, pulmonary ischemia, hemorrhage. Ask the following questions. What analgesics have they had? That makes a big difference. If they've developed a pain threshold and they've increased their over-the-counter or prescribed medications, it's going to make it harder to control them after surgery or something like that there. How is the affecting their vital signs? Is the patient level of alertness affected? Pain assessment on admission, at transfer, or each of new complaint of pain for the presence, intensity, location, duration, and character of the pain. All patients' indications of pain will be listened to. Reassessment should be done at least every 60 minutes, but it says also that it should be checked every 30 to 60 minutes for a patient experiencing pain. Sedation scale, when should you use it? You should use it anytime you're giving medication that can reduce their cognitive ability or give them sedation. What does the numbers mean? Well, the numbers mean that they, like 0, fully awake and alert. That's what that number means. 1 is slightly sedated, easily aroused. 2 is sedated, difficult to arouse. 3 is unresponsive, and S is sleeping. So the S is sleeping. That's if you do not disturb them and you look at them, they're sleeping. For patients who are unable to verbally express the level of pain, pain management should be based on the behavior and physiological signs observed during the objective assessment. Who is responsible for pain control? Doctors, nurses, pharmacists, patient. The whole healthcare team is responsible for those. Okay? You have to take and make sure that everybody is on the board with how they assess pain. Okay? Pain is what the patient says it is, and it is what they do. Have a good day. Bye.